Good evening, everybody. My name is Kavita Prabhu, and I'm happy to be opening this webinar today. We are into our AAU educational webinar series, and the series is supported by Saja Pharma for us today. And indeed, as part of the Arab Association of Urology, we are very delighted to bring to you these kind of online learnings. Just for all your information, today's webinar will be live streamed and will be also streamed on the AAU YouTube channel. You're requested to keep typing your questions into the chat box. And if you want to address it to a particular speaker, please do mention the name of the speaker, but be assured at the end of the webinar, we will take your questions and answer it. The good news also is the CME has been applied for this event, and it will be shared to you as soon as the CME is granted. You will get an email into your inboxes, and you can complete and download the online certificate as well. This webinar will be available on demand after this webinar on our AAU Smart Learning website. We encourage you to visit the website and look at not just this, but all the other learnings as well. Without further ado, let me introduce you to the three moderators that I'm really delighted to support and introduce today. Up first, we have Dr. Yasser Farahat. He's the executive director for the Arab Association of Urology, and he always leads us with his passion, and I think most of you do know him as well. I'm also privileged to introduce our current president of the Arab Association of Urology, Dr. Muhammad Maroon. And Dr. Muhammad Maroon is based out of Oman, and he's a stalwart in the education field as well. Last but not the least, we've got Dr. Raed Azhar, who is a past president of the Arab Association of Urology, a huge individual who supports education and mentors, individuals and groups on a regular basis. So Dr. Yasser, Dr. Maroon, and Dr. Azhar, I'm so delighted for you to be here today and share with all of us your learnings and findings along with the other speakers that we have here today. Dr. Yasser, over to you.
Thank you, Kavita, for introduction. It's really a great honor to start this great series of educational activity, online educational activity, with the support of our partner, Saja Pharmaceutical. And also we are happy to share the experience or partnership with Orsi Academy and John Hopkins with two eminent speakers today. My colleagues will introduce them. My point is about the topic that we selected today, which is the tele mentoring and telerobotic. I believe the era of tele surgery, especially telerobotic surgery, it came strong last few years. And I think we were have a doubt how it will work, how it will succeed, but it proving it day after day that it is coming strongly and overcoming different barriers of traveling and be in person to do some surgery in other area and exchange between expertise. So it solved a lot of problem. And I believe the same is going in the same direction in training, because this is also a challenging part that we are facing here in Arab countries, or especially in the Middle East, traveling abroad for getting chances for or opportunities for training and to be mentored by expertise in different fields, sometimes challenging due to financial or logistic issue. So having a new era of tele-mentoring or tele education is really an interesting idea, and we believe that it will come very strong in the next few years. So I'm happy to have our first webinar for this series of webinars tackling this topic. Without further delay, I'd like to introduce Dr. Muhammad Al-Marhoun, our current president of the Arab Association of Urology, to introduce our first speaker today. Dr. Marhoun.
السلام عليكم ورحمة الله. We are privileged to have pioneers in this area of telerobotic mentoring and training. So we will start with our first speaker, Professor Gert D. Nair from Azorg Hospital, a leading center for robotic and digital surgical innovation in Europe. Dr. Nair will talk to us about tele-mentoring and tele-proctoring in robotic urology. Can it increase quality of care? Professor Nair, please.
Okay, good evening, everyone. I first try to share my presentation. Okay, so I think you can see the presentation, the first slide of the presentation. So good evening, everyone online. Good evening, there in the UEA, and thank you so much, first of all, to the Arab School of Urology and to Dr. Farahat for the kind invitation to show you our first experience with telementoring and teleproctoring in robotic urology. Can it increase the quality of care? So it is a pleasure to have you or to present you our first our experiences. So as introduced, these are my CV points, and I have no conflicts of interest. So this is the agenda of the presentation. I will give you something on definition, history, goals, effectivity, possibilities, and the barriers of telementoring and teleproctoring. So actually, before we start with the next slides, we should first define what is telementoring and teletraining in robotic urology. And it refers actually to the use of telecommunication technologies to deliver surgical education, skills training, and mentorship remotely, something that we as urologists or like senior urologists actually will have to do with our junior colleagues. So it completes or it includes live video-based instruction, the real-time guidance and procedures, tele-education platforms. It allows the expert surgeon to instruct or supervise surgical trainees or less experienced surgeons at a distant location in real time. It can be feasible and effective for teaching both basic and advanced urological skills and to introduce new technologies, of course. And it proves technical competence and is expanding access to high-quality surgical education. And especially during the COVID-19 pandemic, it gained interest, and it was especially interested also for the resource limited or remote or rural settings. So teleproctoring can be a variety of technologies. It can guide from verbal guidance over illustration with interactive annotation on the surgical video feeds towards today actually the tele-assisted surgery that we are able to do with the coming of the new robotics. So as you see, there is a lot of tele from teleproctoring, mentoring, presents, consult surgery to actually telesurgery available. All those terms can be a little bit of confusion, and actually we will use all those terms through each other. I've been proctoring a lot of people and colleagues in robotic surgery on site, of course. And if you are interested in the definition of all those things, this is a nice overview from Dr. Sajdiva from the United States about the differences between preceptoring and proctoring. Actually, preceptoring more participating and greater legal risk, while proctoring is actually more an observer role and less legal risks, and the differences between mentoring and coaching, which is more onto the long-term professional association. So as you see, the proctoring on site of being to the Mont Blanc area and to Finland, it gives you a lot of friends. Actually, is telesurgery, is it really something new? If we look back a little bit, we know that in 2001, Jacques Marescot, which was a French surgeon, he performed the first remote robotic surgery from United States, from New York, towards Strasbourg on a patient doing a robotic cholecystectomy with the ASAP system. It was a few days before the terroristic attacks on the WTC tower, so I didn't get that much attention. But actually, since many years, so almost 20 years, you see that different publications have been done about telementoring in surgery, teleeducation, telepresence, and so on. But actually, then there was a lot of less interest over the years 2010, 2015, 2020. There is some possibilities to do Google Glass or to use Google Glass for remote surgical teleproctoring in Mozambique. There is a Proximy possibilities that was developed in the United Kingdom. Actually, there are a lot of technologies available over the last years to help people on a distance. So this is a TelePro system, what's used in colorectal surgery, a system for teleproctoring and with low latency developed in Japan, was also used from Malaysia to Japan to train people on a distance. But actually what has changed over the last few years, over the last 2, 3, 4 years, actually these are the technology drivers. Today we are available to do high-speed data transfer with the 5G networks, with the fiber networks and also possibly with satellite communication that have been tested, we can actually do high quality imaging and we can transfer it over the internet. It's also less expensive than it was 20 years ago, so the lower connectivity costs are also there. And what is especially new over the last few years, we have multiple robotic platforms that came available on the market that are implementing tele software and the possibility to do telepresence or telesurgery. Also, there are some more clinical drivers. We have surgeons in rural areas, especially experienced in China, and that was the driver that actually a lot of Chinese platforms have developed this tele software. We have the telemedicine acceptance in the COVID area or post-COVID, and there are also a lot of humanitarian benefits that become more and more important. So if you look here, I think I might have forgotten a few of them, but you have the TUMAI from Medbot, you have the Edge robotic system, you have the SSI Mantra from India, you have here the Kangdue system, also Chinese, and you have the Hinotori robot from Japan, are all robotic systems, multi-boom, here multi-card systems that are able to do tele-surgery. So here you see a little video where I'm doing a telestration during a proctoring on-site procedure. But of course, this is with an XI robot. Actually, the telestration was also possible since 2010, but this is also for on-site proctoring and on-site preceptoring. But the new system of Intuitive, so the DV5 robot, which is CE marked since last year, has also new technologies, and also the telepresence surgery is available there. Telesurgery is actually not yet FDA approved, but it can do the telepresence surgery. So with this new robotics coming to the market, we had the honor that since the end of 2024, the TUMAI system, robotic system from Medbot, was actually CE marked and approved for use in Europe, and we had the honor and the possibility to do the first European telesurgery or the first telesurgery case on a European patient with the TUMAI system. We did it from Orsi Academy. That was on the 26th of May. It's almost 1 year ago. From Orsi Academy to Azur Hospital, where I'm working, is not a big distance, of course, but actually we started there and we did the first case, and we started also a prospective trial. And so we were able to do a telesurgery over a short distance case, but actually with a very low latency time of only 20 milliseconds. And we, of course, had to do also a backup surgery. And the surgery went fine. We did a robotic prostatectomy. We've been doing about 15 cases so far, and actually without big problems. So what are the goals of telementoring and teletraining, which is something that from Morse Academy and from my own practice, we've been doing a lot on site, but actually we believe that in the future, our guide or our role as a proctor will change. And we want to improve access to high-level care for also people far away from us, where we have to bridge the geographical barriers and where we can bring surgical expertise to different areas all around the world. We want to eliminate the need to transport a proctor there. It's cost you time, it costs you a lot of efforts. We want also, and I think this is very important in robotic surgery, we want to allow for standardization of technique, and we want to accelerate learning curves. So we'll come back on that later. And it should improve the surgical skills of the proctees, of course, the competence and the confidence, and it should improve, of course, procedure efficiency and safety, which I think is important, very important, and it should reduce complications and also the costs. And this is why we believe that tele-mentoring and tele-training can improve the outcomes and can improve the quality of care. There are a lot of, as I already mentioned, reviews that have been done and so on. We will have a look at the most important studies that we find. So this was a publication from 2023, where actually in the beginning there was looked at the initial experience for the surgeons that was experienced as more than moderate, where telementoring had an effect on the services or on the satisfaction with the telementoring and so on. So it was at least very positively experienced. So this is also a case from the Telepro technology from Japan, where it was used to improve the quality of surgical education. And it's important because they looked at surgical quality, education effect, and social impact, and they could see that actually with the remote proctoring, support for proctoring, the respondents they mentioned, or they scored that surgical quality was perfectly fine with them, Also, surgical tactics was fine, and the avoidance or the recovery of unexpected complications was also expected very, very fine. So the question we have to ask further is, of course, is it effective? There is a little review here from the Journal of American Journal of Surgery 2022 that looked to 25 studies, and they all are citing positive impact, positive experience, increased confidence, and increased surgical skill. But of course, now we look to the point or to the experience of the surgeon. I think what we want to do is, if you feel comfortable with that, if you feel comfortable with teleproctoring and telesurgery, we as proctors and as well the proctees, is that we can also show that actually it improves something for the patient. It should improve the learning curve. It should improve the quality of care. And this is a review, a systematic review from last year, World Journal of Urology, that looked to teleproctoring from different studies. I think it was also using different systems, and it showed that actually, if you that in lab scenarios, the different prospective trials in lab scenarios, where they showed it was better. It enhanced the robotic surgery training and the patient outcomes, but it also included few studies there. This was teleproctoring in live robotic surgery. It was a gynecology. It was not in urology. There are no urological studies available yet, but actually this showed that there were no major technological issues, that there were no safety concerns reported by the surgeons during the teleproctoring of real patients, and there was no difference in the estimated blood loss or complications. And even one study mentioned that teleproctored hysterectomies were actually shorter in time than the in-person cases. And something similar was actually shown in this nice trial, where actually a study showing that if you do a remote training on the DV trainer with, I think, 40 medical students, there was a remote group that received remote training from a proctor that was remote, and there was a group that received a live one-on-one guidance, and then they looked at all different parameters. They showed that the remote group achieved actually higher total scores, in the simulated tasks, and that the trainers in the remote group reported the lower subjective fatigue log. So you see that it is not only an impact on the surgeons, but also on the training, and as we showed in the previous study, on the quality of the surgery. So you see here on the study that the blue line is a remote group and is actually overscoring the control group for the pegboard and for the thread. It is even more clear in this blue line for the tasks of the Da Vinci trainer. So we can presume that there is at least an advantage. The question, of course, is, and this is also one of the things that I am also experiencing when I give lectures and when we share our experiences. I get the question always: do you think there is a need for doing telesurgery in Europe? This question is not resolved yet, of course, but do you need? I always say the same. I think maybe the telesurgery on Belgian level is not really, or on European level is not really the most important thing we want to do. But what I believe that very important might become a role in the future is the role of robotic telementoring, because you have to understand that robotic procedure volumes, they are expected to now we think that we do about 1.2 million robotic surgeries performed worldwide now, okay, which is a low percentage of the total of estimated surgeries done worldwide, of course. So they expect that over the next decade, by 5 years, there might be a rapid growth, 10 to 15%, mainly in urology, but I believe also in gynecology and general surgery and so on. So they believe that actually the robotic surgical procedures percentage will increase a lot. And low and middle income countries, they have more and more access to robotics, especially now today, when we see that the monopoly of Intuitive has been gone with the Chinese robots and Japanese and Indian ones that are coming onto the market. And there are also some key growth drivers. There is a rising demand for precision surgeries, like in urology, gynecology, but also general surgery, of course. We have also, especially in the West here, an aging population, and the chronic diseases are increasing. And we also have more and more technology coming onto the market with ICG, with automated surgery maybe in the future, with all kinds of AI and imaging that are actually put onto these robotic systems to improve the surgery. So you see here a picture of a study was done last year where Vip Patel, who is the president of the Society of Robotic Surgeons in Orlando, performed from Orlando to Angola. He performed a series of about 10 robotic prostatectomies, of course, with a backup on site. Was Marcio Moscovas going there? Is one of my friends. And actually, they've been showing that there is a feasibility, of course, or a possibility to go for transatlantic robotic surgery. And of course, he cannot continue doing that. But if he can support maybe a team that has been trained to do it there, I think this might be a huge advantage. Especially if you look to the learning curves, you see this is an overview of robotic procedure in urology and laparoscopic for the learning curves. You see robotic prostatectomy 10 to 150, of course, defining or depending on what kind of outcomes you want to define. But you see, if you are a proctor, you can go 1 time, 2 times, 5 times to your colleagues to proctor them. But actually, after that time, you have to let them start for their own task. The same goes for cystectomy, for pyloroplasty. You see that the learning curve is not only 5 to 10 cases; it continues even after that. So we had the pleasure to do the first teleproctored procedure as well. That was on the DRUS, which is the Deutsches Robotic Urology Symposium 2025, November, from Hamburg, where I did a teleproctoring case. I was in Hamburg and I proctored one of my colleagues here in Azor Hospital in Aalst. So over a distance of 602 kilometers, the biggest distance at that moment for the European proctoring, where I could take over the console and take it just by a simple press on this button, take it, and help my colleague to do like nerve sparing or bladder, like the more difficult parts of the procedure. We have been doing a teleproctoring case at the European Association of Urology Congress this year in London in March, and I had the honor to proctor a case to Madrid, so it was over a distance of more than 2,000 kilometers because the signal goes over the fiber net. It went to Amsterdam and then to the server in Amsterdam, and from the server in Amsterdam downwards towards Madrid. So you see, I'm sitting here a little bit lonely in a room in the Congress Hall in London, and actually I tried to play this video. You see here operating my colleague Ricardo Brime. From Madrid, and actually before he wanted to clamp, I told him, okay, Ricardo, please 1 moment, I will take over. So I push on the button here and I want to take. He has to confirm and he has to say, okay, I give it to you. And after 3 seconds, you see, I can put my hands to the handles here, to the robotic handles, and I can take over the console and I can tell him, okay, Ricardo, wait 1 second before I would do the clamping. I would check that the ports are fine and I will check that you have everything there. So you see that it offers you a lot of possibilities, and this was also the reason that on the last year SRS meeting 2025 July in Strasbourg, the WHO, so World Health Organization and Society of Robotic Surgeons, they signed a memorandum of understanding where they actually wanted to increase the care and surgery, the quality of surgical care to many people in the low and middle income countries, and where they want to use telesurgery to have access or to extend actually access to care and reduce equity gaps. And we believe that tele-mentoring and tele-training of local surgeons and the local team is a huge opportunity for the future that we have to face. This is a slide that I got from Dr. Saad Al-Dosari from Kuwait on the SRS meeting, so showing that you can see that you can do transatlantic telesurgery, also with support to Africa, to countries here in Middle East that have less experience in robotics where you can support them. Of course, it's not only gold and every medal has 2 sides. So there are some barriers of telementoring as well. We have some infrastructural barriers, of course. The internet has to be reliable, of course. The latency should be checked. The video quality needs to be good. It's not always perfect. You need, of course, technicians that are on the remote location with experience in that. There are also financial and equipment costs for those countries. There are also humanitarian factors. Mentors are short. Mentors are not always available. There can be language barriers. That can be the same with on-site training, of course. And I think for the European setting, the regulatory and ethical issues might be the most difficult ones on the future because it will be most difficult to organize, and all the licensing cross-border and data privacy is something that I think Europe might fall sometimes from that point, and which is not always easy to face it. And some logistical challenges, of course. You need to remote scheduling, clashes, and so on. You have to check institutional support, and you think there's all things that can make the telesurgery, teleproctoring difficult. But we believe at least that we have proved that there is a feasibility, and in the next years we will have the duty to enroll this further. These are some tips and tricks, of course, that I meant to mention you, that you should use like a standard lexicon protocol, that you have to prepare the case to avoid the stress, that you can actually look to anatomical variations, and that you can discuss critical decision making. We have when we did the proctoring from London to Madrid, we had actually take the rules of telesurgery. We made let's say communication lines, but we actually said, okay, when this happens, we will do that, and so on and so on. So you need to have communication redundancy. You have to use different lines of multiple telecommunication just to avoid a dropout, of course. And very important, we are only surgeons. We don't have experience with all those technical things. You need a technical team, like in the James Bond films. You need a queue that can help you. Here you see one of the engineers of MedPod sitting in, I think that was Germany, after his computer checking the signal and so on and so on. So you see there is a lot of technical support needed as well. So to conclude, I want to share with you that I think the Gardner hype cycle is a very interesting curve showing you the running of every technology. If there is a technology trigger, you see always a peak of inflated expectations. I don't know where we are on this curve now. Maybe this was 2001. We went down 2000 in 2005, 6, 10, and maybe now this is again 2026. Or is this the new peak of inflated expectations? Maybe we're here now. I mean, it will go down again. Actually, it's not always easy to predict it, but I believe that Amara's law will be more than truth for the telesurgery and teleproctoring as well, which means that this technology, it will be overestimated in the short-term benefit for sure. We believe, okay, now it will change my life completely. I can do teleproctoring and so on the short term, but on the long term, I think it is underestimated. And I think that in the future, we will realize that tele-mentoring and teleproctoring will be something here to stay and will probably change the character or the fact how we do teleproctoring. So thank you so much for your attention, and I'm open to questions, of course.
Thank you, Dr. Nair, for a very interesting lecture. We will keep the questions to the end of this webinar.
Okay.
Now, I would like to ask Dr. Wright to introduce the next speaker.
Okay, I'd like to introduce Dr. Ahmed Ghazi. Dr. Ahmed Ghazi is a close friend of mine who's an associate professor of urology at Johns Hopkins University School of Medicine. He's the director of minimally invasive and robotic surgery. There, he's a director of surgical simulation training. He's really a pioneer in surgical simulation innovation and training, and he has an active contribution in the tele-mentoring and advanced surgical education area. He will be talking about extending expertise beyond borders, tele-mentoring and tele-proctoring in urology. Dr. Ghazi?
Yeah, sorry, I'm having just a few technical difficulties. If you could ask 1 or 2 questions, I'll be on in like 3 minutes.
Sure. Let me ask Dr. So about the previous presentation, you mentioned there are different, I think we passed the part where telerobotic is feasible because it has been shown that it is feasible. You can do it. But let's go now to the next level, which is how can we make it? What are the different ideas that we can make it as a daily practice, something that we can perform daily, not on in a conference or a feasibility region.
Well, actually, so what I see onto this open or the market coming open in Europe, that I see that few hospital groups, like we had one group from Germany, that was very interested in having the 2My system, because we have the 2My system here in our hospital, but might be any other system as well, just to have it in one city in Germany. I think it was even Berlin, and that was the hospital group. They have like different small hospitals belonging to the same group, and they will use this system because then they can jump into the console when another colleague is a less experienced or junior colleague is operating and doing, for instance, a partial nephrectomy 20 kilometers away, and there is a problem or whatever, they can jump onto the system and quickly taking over. You have to know that, so I think telesurgery, this is teleproctoring that will be for internal, let's say, increasing of quality of care. You have to understand that actually today the program from Gibraltar or London Clinic to Gibraltar is also running. So you know that the Gibraltar is part of United Kingdom, where actually they have a TUMI system, a robotic system, and where Dr. or Professor Das Gupta started, I think, about 2 months ago, about March. They started doing a real robotic telesurgery program from London towards Gibraltar. These people have the national healthcare system of United Kingdom. So in the past, they had to travel from Gibraltar to London to have the surgery, and now they can stay there and they can stay with their family in their own local area of Gibraltar, and they can have a radical prostatectomy from London being done in Gibraltar. The other point is like the same interest coming for the Faroe Islands. Faroe Islands are very remote islands above Scotland, belonging to Denmark, and also Denmark is looking to an interest for putting a system there and doing probably remote surgery from Copenhagen towards Faroe Islands. So I will let the word to my colleague, Dr. Ghazi.
Can everybody hear me?
Yes, we can hear you.
All right, excellent. And I apologize for any of the technical difficulties. I had to move from one laptop to another. For some reason, it wouldn't share. But again, great work. I have to commend Orsi Academy, Dr. Nair, for really presenting some of the groundbreaking work in telesurgery and teleproctoring. What I am going to actually present, and again, thank you for the Arab Association and Dr. Riyad for his invitation for this very important webinar. I'm going to touch base on something that I believe is completely undershadowed by telesurgery, is really telementoring, and also telepresence during simulation training, because I think that allows us to have a very low risk environment, allows us to teach people beyond borders. Because if we look at truly what we struggle in order to train people, and in not all places do you have a great center like Orsi Academy that is somewhat central within Europe, but for the entire rest of the world, it becomes very difficult for them to train across barriers. And not only are you limited by the availability of models that are truly realistic in their nature, but also proctors. Like you had touched on before, proctors are a rare breed. It's not easy to find a good surgeon that understands their technique very well, that is able to teach. You have a lot of good surgeons that really cannot teach that well. So this really allows breaking down the borders of training and simulation. And so what we did is we really combined 3 unique technologies. We provided very realistic, high fidelity, low biohazardous or zero biohazardous models with glasses that allow the trainee to see both. Now, this is not in robotic because my colleague has touched in robotic. We've done this in robotic surgery, but I also wanted to show how we were able to do this outside robotic surgery. These glasses enable the trainee to see the view that they see, but also enable with this mixed reality software to allow the proctor, as you can see, to see an overlay of what the trainee is seeing. And so the trainee sees a hand inside the field that is completely remote. And so using a combination of these 3 technologies, we use this for ultrasound biopsy of the prostate, we used it for ultrasound-guided PCNL, and we used it for penile prostheses. So let's start with what we did on an ultrasound base. So the thing about these 2 and why we chose these procedures is we really needed to push the limit here, because we wanted to see if we are able to teach in a remote fashion using a combination of both the point of view of the trainee in addition to the ultrasound. So you're looking at 2 views, not only one. And so we decided to do this really with a study. And the study was a pre-post test where we had 20 novices with less than 5 case volumes. These are our junior residents over multiple years. We did a randomized test based on pre-test. So everybody did the first test, and we used that as a basic test to randomize them so that we don't have a group that is better or intuitively better or naturally better in one group versus the other. We randomized those. We gave them pre-learning because in order to really be able to optimize remote training, you do have to give them some understanding of what you're training them on. And this is usually through an online didactic lecture. So we did We gave them brief educational videos about anatomy, ultrasound views of the prostate, how to use the ultrasound, a little bit of an idea of the model and what differences it has from true life. We had assessments of performance that were very granular and that were embedded in the model itself. And we actually had separate colors. So some people would say, well, the pretest saves as a test that they can continue on. No, the pretest was a prostate that is colored in one color of the hydrogel. However, the post or their post test, so while they were training on a prostate that doesn't tell them where the cores are. The second or the post test was a test in which we can get the accuracy of the region in which they biopsy based by just the color of the prostate model itself. So to give you an idea, if you look down on the left, that is the actual model that we used, and it's made with different colors. And so not only are you getting different colors of the cores based on where you biopsied, we also actually found that you can get 100% of the same color, and it can vary all the way down to 0%. Right? So volume measurement was part of the assessment. We had them do training over successive times. So each one actually had 5 training sessions. We looked at domains also asking feedback from the trainee and also from the proctor itself. And this is compared directly to in-person teaching, which is the standard of what we do. We looked at domains of usefulness of the teaching, clarity, accuracy, timeliness of the feedback, and the quality of the feedback. And this allowed us to assess the difference between both of these. Also, for the ultrasound of the kidney, we use different things like the time it took to access the calyx. Are they accessing the actual correct calyx? How many attempts it took for them to actually access the calyx? And same thing, we had the same training domains that we looked at.
Okay, so I'm finding the urethra.
So this is an example of really the training session. And you can see me on my kind of master console. And down here on the right is the view that the trainee can see from the glasses. You see how my hand is able to creep in? And the software is very simple because it allows you to have this webcam that merges both of these views. And I found it actually very useful to have props. So I had a 3D printed phantom that was solid off the prostate. I had something that looked like an ultrasound probe, and it allowed the trainee to able to understand where they need to replace both. And so see the subtle movements and the subtle instructions that I'm giving them. This is the trainee wearing the glasses and standing where they're looking. Where they're looking, I can see a picture of the ultrasound alone, and I can see on the right screen of mine a picture of their point of view so that we see where they're looking at. And so this is the instructor view during the training sessions. So when we compared both groups and compared the mixed reality to the in-person training, the pre-test showed this is their performance in their ability to get. So these are the percentage of the course. Pre-test was 18%, post-test was 75% accuracy with an increase of about 60%. In person, they started slightly higher, not significantly different, about 26%, but they reached a ceiling of 62% with only a 35% increase in their ability to learn new skills. So this was very instrumental. When we looked at the usefulness and the clarity or the differences between both modalities of training, we found similarity in the usefulness, the accuracy, and the timeliness of the training itself. And you can see here, quality is actually very, very close. So the overall change was, again, 63% compared to 45%. And we actually did a mid-test in order to see where they were. And you can see there's a steep rise in the mixed reality training session, very steep till the mid-test. And then they kind of plateaued, but continued to rise. This is also looking at the percentage of the cores, meaning that the lower number actually would be the average percent where they got 100% of the color that they got. You can see actually the in-person went worse before they got better versus the mixed reality got really good and then they stabilized because they got really good very quickly. We also looked for the percentage of missed cores, so cores in which 0% of the color was there in the post-test, and you can see that there is a steep decline in these missed cores in the mixed reality group compared to the in-person training group. So basically what we said is we found that mixed reality and in-person training are equally effective. We found that mixed reality training is perceived to be worse. So when we asked them feedback before they did the final test, they felt that there was a disconnect between them and the proctor, and they felt that they weren't getting all the information to some degree. But then when we sat down and did qualitative interviews and we showed them their results, we actually found out that mixed reality training provides a better quality of training because of one reason, that the proctor cannot take over. You can see the proctor trying to hold the ultrasound probe from the trainee, and they can't, because that's a natural intuition that a proctor does. Let me show you. Actually, they were forced to break it down and explain the movements in small chunks that the trainee can understand their ability to do it and copy it. So it took longer, but the quality was significantly better. So this was very insightful in our presentation and in our study. So this is looking at ultrasound, and this is a far more complex procedure because it's not only how the ultrasound is being held, but also they have another needle in their hand that they're trying to correlate with an ultrasound image. And so if you look at my hand, you can see how I'm trying to direct how they're moving. And at the same time, I am giving them props. So you will see these props as being very useful in the ability to give them to understand. So again, we had a 3D printed kidney, and this was potentially embedded. This was given to the in-person instructor. They used it, but didn't use it as much as I used it because I couldn't tell them, here's the kidney. I had to show it to them and explain it to them very clearly. Same here, you can see the number of attempts with the mixed reality group continued to go down in the blue, while in the other group, you see it went down. So these are the number of attempts, meaning they took longer to get access to the upper pole of the kidney.
Is in the middle of the screen.
So this is just looking the score, also the time required to achieve that access. So again, a lot less. And you can see that the mixed reality group takes a steep dive and then it starts to actually plateau. And we had retention tests. So these were tests that were done 3 months after the post-test without any training in the beginning. Here you can see a score that we actually had a grading system for this to give them an idea of what they're dealing with. So you can see the grading system first went up in the mixed reality and then went down in the retention as expected, but there was no significant difference in both. So these are just the results saying that mixed reality is truly, they feel frustrated in the beginning, but then they start to realize the value of the proctor really having to explain and break down the procedure very granular for them to be able to train. Looking at penile prostheses, which is an open procedure, which we thought was going to be easier to train, turns out it's actually significantly more complex because of the minor movements. And so this is similar to robotic surgery. The minor movements required to be done with the instrument. And this is where taking over the instrument from the trainee and demonstrating what they're doing might actually be very useful. So same concept, we had the glasses, or we actually had an iPad. And this is my setup where I'm standing. I can see the view of the trainee that's overlaid. And I have my webcam here. It's a webcam that you buy off the shelf for a couple of dollars. And I am explaining the process to them. We put a white sheet on the floor or on the base because that allows less noise. Because again, the trainee has some level of perception overload, which I do think that is why they were frustrated in the beginning. We're starting now to use the actual wearable mixed reality, like the Apple glasses or actually the HoloLens, that might give them actually a better way of viewing it without being distracted by a side view monitor or an iPad in the view. And this is a kit. So this is actually done across. So we were in Baltimore, where Johns Hopkins is, and we sent this kit with a stand and headphones and a camera. And this was, of course, sponsored by a company with our models and their implants.
All right, so
this is, again, an example of how I did this. I want to really go forward and show you certain parts, right? So not only was I drawing on the screen, but also, if you look at what I did, I started to get the instrument itself. So I started holding a scissor and I started holding a dilator. And I told them, just stay, don't move your head, and I'll show you exactly where the dilator needs to be placed. And so I'm taking my dilator and I'm overlaying it on the model to tell them where the tip of the dilator and the direction in which they should go. And then I move away and then have them demonstrate it to me virtually first, say, okay, this is what I'm going to do, and this is how I'm going to move, and then they actually get to do it. So it's very interesting, that approach of showing them, and then you show me, and then you show me how you do it. So this is an educational approach that is very well standardized in the way that you're supposed to teach people to do complex skills, which I think surgery is one of them.
The incision is going to be right across.
So this is
over here,
us to New York.
right here, at the penile junction, a little bit lower.
And you
There.
can notice we changed the colors of the gloves because the trainee was so immersed that they thought that the glove that was coming in was their hand. So we told them, no, they have to wear different colored gloves because that allows them to understand and conceptualize whose hand is whose. This is also an interesting part. So that's the incision. This is now the dilatation.
Right, so you're pushing the urethra up and the corpora down. Now insert the dilator into the corporotomy. And you want to stay lateral. So you want to be heading this way towards his shoulder and protect the fossa. And now dilate laterally. See a hump all the way
so
up.
He's following the actual instrument. Incredible.
Okay, now take it
These are
deeper
again different parts. This was actually a difficult part. This is actually in placing the reservoir, which is very difficult not only in the model because it's replicated after a human, but also being able to explain it.
Try and push down into the transversalis fascia and perforate with your finger. But if you can't, you can use a tool, like a Metz, for example.
So her hand is a little bit lateral, and when he corrects it, he starts moving his finger how it's supposed to move, and the trainee is copying.
Leave your finger in there, and then run the Metz with your other. You're going to expand that hole, and then take your Metz out as you're expanding the hole.
The proctors feel that they're doing the surgery. They feel like they're holding the glands and they're moving it. And we found that animation being very useful for the trainee on the other side. Again, this is an example of the pump placement, but these are results that we got. When we looked at the mixed reality, you can see the steep decrease in the errors that happened very early on in the mixed reality. And then there's a slight plateau, which is where we expected. This is where it's 2 standards deviation from experts. But if you look at the in-person, there's this variation between going up and down and up and down. And I think what mixed reality was able to do is that it gave everybody a basis for them to have to explain and over-explain certain steps of the procedure, which is very important for a novice when they need to learn. And this is really the conclusions that we got. We're taking all this and we're currently doing a test with Savato from Baltimore to California in being able to do telerobotic mentoring and actually simulation between both events, between both sites, where we have complex gastric cancer models, complex partial nephrectomy models, and proctors are teaching residents and residents are teaching proctors from different institutions. So as explained from my colleague before, it's not only being able to take experts to have them share their knowledge with everybody else, but think about this. If I'm at that institution, I'm being trained by the same people. Would be great to mix it up a little bit and be able to train from people in Saudi Arabia and people in the West Coast and people from Canada and people from anywhere in the world, where you're able to get this different flavor of different experts because everybody does things a little bit differently. So I think tele-mentoring and telesurgery, whether it's for really benefiting patient populations from low income, but I think in places where surgical care is to some degree established, we should really be focusing on training more than just doing surgery for patients, because you do not need a backup surgeon or a backup team on the other side. Thank you.
Thank you very much, Dr. Ghazi, for this really thought-provoking and excellent work. It really shows the real value of telementoring. I'm not sure if you have questions. Let me start with the question that came to my mind. So is there like a study that shows those who are trained on these mixed reality models versus those who did the real training? What is the outcome of these trainees? Like, are they doing the same? Can they do, once they're done with these training, can they go ahead and do it in real patients? And what is the difference?
Yes. So this is a very great question. So we trained them to a proficiency level, and that proficiency level is based on two standards of deviation from an expert performing this procedure using the metrics that were built in. And so what we do is this is their pre-surgical competency. And so both of them, because our study was not saying that mixed reality is better than in person. Our study was to say the equivalency of mixed reality versus in person. So you can switch mixed reality in person with mixed reality, having this technology available. Both of them actually achieved the proficiency levels that they required. However, mixed reality got there faster, although their sessions were longer. So we had sessions every week for 6 consecutive weeks. The mixed reality sessions took about an hour. However, the in-person took about 35 minutes, almost half the time less. And I do believe that was because the training wasn't complete. By taking over the tool and showing them, the trainee is just copying you like a parrot. But when you tell them, no, twist the probe, move it to the left, and then move it in, now you see the view, they realize there is a learning process that happens in their brain where this actual information is embedded in their brain. And they come back and they don't do the same mistake. And so although the sessions took longer, their outcome at the end, because the number of training sessions were the same, was higher compared to the others. Both of them reached a minimum level of proficiency that would allow them to go to the OR with this technology. But if we take this and start to think about training for people on simulation to a certain level, and then following that training towards patient care is great because the continuity of the proctor is very important. So we ran a course in Saudi. We train there. And then these same people are going to go and get trained by somebody else on patients. What if you can have that continuation of proctoring along the entire learning cycle? I think that will greatly reduce the learning curve because they have established a relationship and a language that allows them to move forward. So I think that's where the magic of this technology comes.
I don't know if you have any other questions.
I may ask Dr. Ghazi, if you would like to apply this telementoring in the Arab region. So how do you think it will work? Through a personal contact or through an institution organized pathway? And is it going to be paid service?
Yeah, this is an incredible question. I'm originally born in Bahrain, raised in Egypt, and then moved over to the United States before spending a couple of years in Europe. So that's my homeland. And the idea to give back, this is what intrigued this way. I think a lot of us now think that if we want to do training, we have to export everybody from here to there. No, I believe all you need to export are the models, or if there are models available there, this technology is very readily available. This technology is a webcam, a HoloLens, and really a software subscription that's about $500, $600 a year. It does not need any further equipment for this type of surgery. We are now looking to do it, believe it or not, with HOLIP, laser enucleation, because again, it involves looking at a model and then looking at a screen and being able to understand different things like the laser settings, et cetera, et cetera. I believe it's very safe to do it in simulation because say an error happens, that's fine. And these could be very beneficial tests to do prior to doing it on patient training. But yes, this would be something where we would love to partner with the Arab School of Urology and other entities over there in the Middle East and the Arab region and be able to actually spread. This is why I meant breaking down barriers. We do courses here at Johns Hopkins where people from the region fly to us. That is an incredible expense. If we're able to use that same expense in running up these courses, I think it will be a very quick standard of care.
Yeah, great. Maybe one more question. What about, you've touched on the feedback of the trainee that they like it because the mentor is not actually touching because this is our insect that you want to touch, you wanna let me show you and you take over. But what do you think about the feedback of the proctor? Like how do you feel about it and what is their feedback?
Yes, that is a really good question because we realize that not everybody, of course, all of us know that not every good surgeon is a good teacher. But what we've realized is it takes a special type of teacher to do remote teaching. Patience is key, and your ability to really be able to break down the task. So what we are now starting, or what I am starting to develop, is a train the trainer course for telementoring and telesurgery. Because I think this is a new type of training. And so you can't just take the training that you do and copy paste it and put it in the training for telementoring and telesurgery. You need to, so we sit down and we brief the proctor, we walk them through, this is your handbook, this is how you respond to certain queries, this is how you take a task and break it down. You have to really think about this. We have them try the technology with us so that they understand the difficulties of this technology. We had some issues with the delay of voice, and so they know they have to talk, wait for a second, and then get the answer. And so there's a little bit of learning curve to the technology that requires a specific type of educator to do this. So I agree. You will need to train the proctor to develop this, but then if we do this enough, then it'll become a standard of care. Unfortunately, nobody trained us to be in-person trainers. We just used what we got trained with to use the same way, and sometimes it's not a perfect science. But if we now set a standard for how we train with this, and maybe it's a collaboration between us and Orsi and the Arab School of Urology to maybe develop a white paper to say these are the guidelines that we think everybody should follow when they are training people on this specific type of technology. Because I do believe that is where this technology is going to really get stuck in the mud. And so I think we have to address this before it becomes an issue.
If I may ask Dr. Nair, just one more question to Dr. Nair. Do you think the tele mentoring will be a prerequisite for certification of robotic surgeons? I mean, before they start a new robotic surgeon, before they start doing surgery, that they have to have a certification of tele mentoring?
Actually, it could be an opportunity in Europe. Actually, we will start the program of micro certification, meaning that as a urologist, you are allowed to do any urological procedure, but more and more in the future, with support of European Association of Urology, you will have to prove that you have a micro certification in certain procedures, and I think that actually today. The rules are coming on and on. The tele proctoring could be in a modality to check that people are actually enough proficient to proceed with this surgeries. So for a certification, I think it can have a good opportunity. Yes.
If you allow me, I just wanted to answer a question came from Dr. Hussam Al-Hamas. He is asking, is AAU or Arab Association of Urology are working on a strategic plan and arrangement to start a program of tele-mentoring? Actually, yes, but working in this direction, it needs a lot of preparation. So we are almost a year now, we are working to establish a physical training center belonging to the Arab School of Urology. And we are in touch with Orsi Academy, Dr. Alex Motri and his team to have some kind of partnership. At the same time, with Dr. Ghazi on John Hopkins, we are discussing several times how to establish a well-structured programs with establish the required equipments and technology to make it on a regular basis. So I hope maybe our plan is to be in 2027 to come in reality to be feasible. But in the current time, we do it in a pilot study. In 2 months ago, we have with Orsi Academy some kind of collaboration here in Dubai to have in-person robotic training. So step by step, we are working to establish that. I hope soon in the future we can establish the tele mentoring that can save a lot of effort, time, as Dr. Ghazi and Dr. Nair mentioned, to avoid the expenses of traveling, of mentors. And this also very important, as Dr. Ghazi mentioned, TOT or training of trainers, because you cannot exhaust one mentor to run a lot of activity through the year. It will not be easy, but having building capacity and training other trainers, that will be also one of our targets. Before closing, I'd like to thank our speakers today. It's really very insightful and very important topic that we are happy to raise it and to make more awareness about the importance of tele-mentoring and the tele-robotic in our region. Before closing, also, I'd like to announce about the continuation of our series of webinar, and thank you for partnership with Saja. The next webinar will be about interesting topic about the bladder cancer, and especially focusing about the innovations in diagnosis and the treatment, especially for non-muscle invasive bladder cancer. And also, I'd like to invite all our members or attendees to register for individual membership. If you can scan the barcode, it will be easy to achieve all benefits that you can get from our e-learning platform and the participation in the conferences. Most important as well in our region is the research, and if you can scan here, you can get free access to the Arab Journal of Urology, and where you can read the latest article, and you can also submit your original work to the Arab Journal of Urology, which is growing nicely and published by Taylor and Francis, and the impact factor is growing nicely year after year. And most important for us to see you in person very soon in Jeddah for the AAU annual conference that will be joined with Saudi Urological Association and Saudi Urolithiasis Days. It will be from 4th to 7th of November, and we have focused this year about hands-on training. We are crossing more than 15 hands-on training and workshops, and we have more than 25 instructional courses. So our main focus this year to enhance and leverage the education and the training, especially to our young fellows and young residents. Last but not least, our partner, I'm not saying sponsor, it's our partner, is Saja Pharmaceutical, is really matching our vision and mission to establish and enhance the training in our region in the Middle East and in the Arab world. Thank you again for everyone, and for attendees today. You will receive the CME in a couple of weeks by email, and you will have the opportunity to send your feedback about the webinar. Let's to understand the strengths and weakness, and let's to have it more successful next time. Thank you again for our speakers. Thank you for my colleagues, Dr. Marhoun and Dr. Raed, and looking forward to see you very soon in the next webinar.